Thank you all very much for joining our webinar today on Global Warriors Access Challenges and Experiences with Sickle Cell Research. I'm going to pass it over to our Research and Clinical Trials Co-Chair, Dr. Pael Desai, to kick us off with opening remarks. Thank you all.
Well, hello, everyone, and welcome to this global seminar. We are so very excited to be on and excited to be among these group of colleagues, friends, patients, and families to talk about the state of sickle cell research, access to global research, and where things are. So session 1 was incredible. We learned from so many different regions about what is going on, what are some of the limitations, what are some of the access issues that people face in terms of clinical research. And we hope to continue that with a couple more presentations today, followed by some discussion about different platforms and examples of community engagement, which we know is so critical in this field. And then I am incredibly excited that we get to end with the Global Warriors perspective. So we get to learn from patients and families about what this is like on the ground in different areas of the world in terms of access to research and what happens. So without further ado, we will get started and talk to 2 different areas, regions that will talk to us about their perspective.
Thank you to the organizers for inviting me to this meeting. I will talk you about the current state of access to sickle cell disease research and clinical trial engagement in Central Africa. I'm speaking on behalf of REDAC, Network of Sickle Cell Disease in Africa. As we know, according to the WHO data, in Central Africa, most of the countries have a very high prevalence of HBS carriers. It's around 15 to 25% of HBS carriers. And the majority of these countries are countries that are surrounding DRC. DRC is in the center, DRC is the heart of Africa. And in the REDAC countries are also involved other countries, in spite the fact that they are located in the east part, just like Uganda, Tanzania, and so on, where we have organized a meeting in these countries. And we have also Madagascar, which is involved in the REDAC project. So globally, we can say that we have 300 million of people who's living in this area. And this area is also a place where malaria is endemic. So globally, we have 2% of people who's affected of sickle cell disease. And in absolute number will be is around 6 million of people. Each year, annually, we have 135,000 new cases of sickle cell disease. Population of individuals living in these areas with sickle cell disease is very high. Yes, I said around 3 million of people, but these people is underdiagnosed. And we have only very, very few warriors in these areas. About newborn screening, I can say that most are preliminary studies that are conducted in big countries, majority in the capitals, and we have only few data in the rural areas where we know that live majority of the African people. And we have no national registry, even though great effort is done in many of these countries. For example, in DRC, we have 3,500 cases who are registered, who are recorded in a digit database. Positive sickle cell disease diagnosis rate is very limited concerning the prenatal and antenatal screening. But fortunately now we have an increased number of prematrimonial screenings. Mortality rate, at contrary of what is reported in literature, we have now new estimation of mortality rate in under 5 children. It's around 35% and not 80%. Current therapies approved. We can access to penicillin, folic acid, vaccines against pneumococcus and Haemophilus, but we have limited access to opioids and unfortunately very, very limited to hydroxyurea, the main drug that we need in Africa. To my knowledge, we have only very rare transplants programs in our area. Two things about current availability of sickle cell disease clinical trials. I can say that most of these steps are just the first steps for the conducting of clinical trials, except the use of hydroxyurea in children aged less than 5 years, which is conducted by Russell Weil from Cincinnati Hospital in 4 African countries. We have also a study on the young mortality estimation in sickle cell patients, and coupled to the heart and vascular complications in sickle cell disease patients. These 2 studies are conducted by Brigitte Rank from Paris. We have conducted a large program of newborn screening in 5 countries, and now we are able to give an estimation of the prevalence of newborn sickle cell disease in these different countries. COVID-19 seroprevalence in sickle cell disease is a new study which is conducting in DRC because of the high use of different herbal medicines and the very few use of vaccines. We are also conducting a study in Benin, Cameroon, and DRC and Gabon on the relationship between Dipty Jain and malaria resistance. What are the current barriers? We have only a limited financial support from the government. We have no sufficient education of health workers. They need training. It's the reason why we try to develop partnerships with the North in order to make exchanges between our health workers. We have limited technical support. We have a great problem of coordination because most of the African countries are working alone, and we have only few networks working all together. It's the reason why RIDAC is making a great effort to make to develop straight contact between the African leaders. Unfortunately, we have less access to grants, specifically to grants from the U.S.A. Thank you for your attention.
Hello. Good evening. Am I audible?
Yes, you're great.
Yes.
Thank you.
Okay. Good evening. I come from India, and I would like to thank the organizers and congratulate them for having such sessions every 3 months. I look forward to future sessions also. Next slide, please. India, as we know, is a large country, and is the population-wise the second next to China. And sickle cell is not new to India. The first case was seen by Pushback in 1952 in a tribal population. And since then, there is a belief that sickle cell disease is only seen in tribals in India. That's not true. It's equally or more seen in other population also, that is non-tribal population. Now the numbers which we see here, 1.4 million people in India has sickle cell disease, which is a huge burden. I would say these are all estimates because what we have no registry today, and there are mainly the sickle cell patients are in the periphery at the village level. As you know, most of the population live there in India, and the number mentioned here are mainly from the tertiary care hospital. So I don't think till we have proper study, we can say that we have 1.4 million people in our country. Now, there has been the changing epidemiology, I would say. No, of course, the epidemiology did not change. We looked for sickle cell disease in other states. Initially, it was only 5 or 6 states in India which were known to have high sickle cell burden. And now we know that 6 more states have shown equal prevalence of sickle cell disease in India. But one unfortunate or fortunate thing I would say, sickle cell disease is not much seen in metro cities like Delhi, Mumbai, Calcutta, or Chennai. That's why it is, I think, neglected disease because it's seen in parts which are not very prominent. I come from Central India, and the haplotype which we have seen through newborn screening, very few centers have molecular diagnosis facility, and it's about 94% of them are Arab Indian haplotype, which have very high hemoglobin F. On an average, Indian population will have hemoglobin F variable from 16 to 22%. Hence, it was thought that Indian sickle cell is mild, which is not true. There are other factors which affect the phenotype of sickle cell disease, and much needs to be done in our country about it. Next slide, please. Now, this slide is a pyramid, a true what our country is. Most of the population is at the base, most of them, and very few you can see at the tip from where I come, which is thought to be Institute of Excellence for Sickle Cell Disease. So how are we going to reach the bottom? So we make use of the village Anganwadi multiple health workers, and still the mode of diagnosis there is solubility test. I don't know how many of you have heard of it or still continue to there, but let me tell you, for my country today, that is the best thing to detect. Now, the problem is, in spite of all this, which I've written here, we have telemedicine, we have health camps and everything. The problem is, once we diagnose, there is no structured proper follow-up or counseling of the patients. Just giving them a card that they are either homozygous or heterozygous or normal is not enough. You need to do something for them. It's unethical to leave them like that. However, efforts are being made now to take care of that. The other thing I would say here is we have facilities at the Institute of Excellence, which are very few. I would to number, we'll have 5 to 6 such institutes where we have comprehensive healthcare, which is available anywhere in the world except a bone marrow transplant. We have prenatal diagnosis facility, which is being done very well. Neonatal screening, again, I think many centers have started doing neonatal screening. However, once the patient is diagnosed to have homozygous sickle cell disease, there is nothing much to offer them. There is no expertise. And so there are only again 4 to 5 centers who are following the patients of neonatal screening. Other thing I would like to mention is about 10 to 30%, depending on from which region you come, we have double heterozygous. The commonest is sickle thal. Next is sickle D, Punjab. We rarely see, I think I've hardly seen 1 or 2 cases of SC in our population. Next slide, please. Yes, here we can see the triad of presentation. Of course, all other morbidity is present, which you see anywhere in the world. But the triad is, of course, pain, infection, and anemia. Very common. One thing I would like to mention here, the bacteremia, the causative organism are different. Of course, we do give penicillin prophylaxis. We give them vaccines, which are given anywhere else. But the organism is gram-positive. Usually Staphylococcus, gram-negative, E. coli, Klebsiella, Salmonella, yes, and malaria. Malaria is as common because the common belief in our physician is sickle cell, they do not suffer from malaria, which is not true in our country. And you can see here we are comparing the newborn cohort, which is, I think, from my center, from Central India, and the non-newborn cohort with the cooperative sickle study, which is documented from U.S.A. And you can see that the pain crisis, the screening sequestration, and all other morbidities are much more. If you look at the mortality, mortality is, of course, much more in our patients than what has been documented from elsewhere, except Africa. Next, please. So I just want to say that the severity is there. The other thing I want to tell is the severity also varies from site to site in India, because in West India, it is milder, while in Central India, it is very severe. So it has a very heterogeneous presentation. Now, of course, government are giving facilities where we have free investigations, treatment, everything, hydroxyurea, penicillin, anything they take is free. They have travel concession, which is there in many other countries. Monthly, I think now they are getting 1,000 rupees per patient. Every month they get 1,000 rupees. And in exam, they get an extra hour. Now, since 2016, it has come under Disability Act. Means they get special privilege in admission to educational institutes and other, not jobs, but not yet jobs. Next, please. Next slide. This is a very controversial thing because our patients have high hemoglobin F and the role of hydroxyurea. Yes, hydroxyurea is very liberally available in our country. No problem with availability. But somehow the compliance is not good. And because there is only the dose available is capsule 500 milligram. So some people will give once a week to adjust for the dose in very small children, alternate day. So all sorts of regimes are used and not the ideal one. While some like me will make a powder form and then divide it into different packets of hydroxyurea. Now the studies in India are many, and they are mainly observational studies in hydroxyurea. Next, please. Next slide. They are observational. Previous, please. And it's like, because it is the hemoglobin F is higher. Next, previous slide, please. Hemoglobin F is high, and also because there is problem with the monitoring of the patients. You know, patients, they live far off from the village. It's so difficult for them to reach us. And it has economic implication. Also, our outcome is not hemoglobin F, increase in hemoglobin F, which is in elsewhere in other countries. Our out infusions and whatever indications. Next, please. Next slide. Next slide. Can I go to the next slide, please? Yes. Now, these are the guidelines. They are though not evidence-based in our scene. And there are such parallel work going on throughout India. And this is a manual which has come up. And here, I think no, it's not much used today. However, I think there is a new updated guideline which is coming up, and it is quite possible that it can be used widely. Next, please. Next slide. Titration of HU, I think I can miss this. That is one, there is a need for RCT to compare fixed dose which we are giving against the acceleration. I don't say we don't accelerate the dose. Of course we do. I think 20%. Hello, yes. And just to say that India, many countries can make India, and you can see that each state needs a special recommendation. Next, please. Next. I think I've missed one slide of challenges. Anyway, I don't think I have time. The most of the research work in our country is the postgraduate students most of them in our part where there are more sickle cell patients will have thesis work, PhD doc who do on sickle cell disease, which is not very well published and so not available in the literature. Indian Council of Medical Research, yes, they have come out with the projects, but not enough. Looking at the burden of illness, CSI, Rizana. Now what has come up with is the multi-population, not in the non-tribal population, which is the need, because the natural history of sickle cell disease in India is very different from what we see in other part of the country. The biggest problem I see today is there is no registry. Another had any partnership with other countries, which is very important, I think, because we are very different and India can contribute to the world. And of course, India itself needs to revise itself. Thank you. I think I've taken more time. Thank you.
All right.
Well, no, now, yeah, we're passing it over to Stephen, but I will say, Dr. Jain, thank you for all of the time you gave us. That was excellent, and we really appreciate your time with us today. And Stephen is now going to take it away. So, Stephen, without further ado.
Thank you, and to echo Tessa's comment, thank you, Dr. Jain. That was very insightful, and I think to your point about improving global partnership is very key. So, thank you for sharing that. All right, so I'm going to share my screen and let's go from there. I think I might need access to be able to share. Perfect. Okay, so hopefully everyone can see my screen. Again, thank you everyone today. My name is Dr. Stephen Boateng. I'm actually here with my co-presenter, Cassandra Trimnell, who is the founder and executive director at Sickle Cell 101, which is, the work that we do is really ensuring that we can provide education, research, and awareness from a global perspective using all our different platforms. So I'm really excited to be here and kind of follow up from our first webinar and give some key insights from what we're learning so far and what we're doing to improve and address that unmet need in research for sickle cell. So as you can see here from our overview, what we're going to do is really take a quick step back, right, and evaluate the current state of research for sickle cell. I think all our presenters from the previous webinar and even from today have really emphasized some of the challenges that we have in terms of research. We're going to take a quick step back and look at that. We're going to spend some time really talking about what we at Sickle Cell 101 are doing to help address a lot of these things with our platform called Sickle Cell Studies. And we're going to end this conversation looking at some examples of some of the things that we're doing in terms of a patient-centric approach to research. So we'll end with some key takeaways and as long as some Q&A too. So that's going to be what we're going to discuss today. And I'm actually going to turn it over to Cassandra.
Hello, everyone. Thank you so much for having us today. Let's go ahead and go to the next slide and jump right into this. All right, so first and foremost, to Stephen's point, I like to start off by taking a step back. And, I am an adult living with sickle cell disease. And so this is personal for me. Treatment options and research is personal. As you all know on the call, for the longest time, we did not have treatment options or too many treatment options available. Hydroxyurea was approved by the FDA in 1998. And then, as of recent, we have 3 additional drug therapies. So as someone living with sickle cell and not necessarily knowing about that hydroxyurea was an option for me, the state of mind was to kind of just ride this disease out until the wheels fall off. So it is extremely important that that we get people engaged in research and that we do have additional drug therapies. I think we've come a long way, but we've got a long way to go. As you can see, we have these 4 drug therapies. I personally am on 2 of them right now. And so we've come a long way, but we've got a long way to go. We can go ahead and move to the next slide. So how do we get the community engaged in research for sickle cell? So it's a big task, being able to meet the community where they are at is a big part of all of this. This you can see here is an example of a study email. If you look at it, it almost looks clinical. It doesn't look warm. It doesn't look inviting. It's just, here are the details, do you want to join or not? Not very engaging. And this is how we engage the community currently for research. This is a survey study. Sometimes they're survey studies, sometimes they're clinical trials, but they are pretty clinical and not very engaging. So I just wanted to share that example. Another example is clinicaltrials.gov. This is the resource that we have to find out and identify what research looks like, what clinical trials are out there. I don't know if you all know how many patients use this site, but as you can see, it looks very clinical, not very inviting, very, very just not engaging. If you click on one of those study profiles, the terminology isn't very patient friendly. You can easily get lost. It's not a great site to navigate. And so this is what we mean by, difficulty with patients understanding. If you give them this resource, it is kind of hard to navigate. Lastly is access to clinical trials. A lot of times, I think what we have this understanding that the community doesn't really want to participate in clinical trials, but our experience has been actually the opposite. People do want to participate in clinical trials. It's just awareness is a big part of this, and they simply do not know where to find clinical trials. A lot of people don't know about clinicaltrials.gov. So for those who are interested, the one resource that we have to give them is clinicaltrials.gov, which isn't very patient friendly and it isn't very engaging. And so as you can see, we have a lot of work to do to get to where we need to be in terms of engaging people living with sickle cell disease and participating in clinical trials. So the last part of this is informed decision-making. Is this study right for me? Are people getting the correct information? Are people feeling pressured into this? So of all of these steps, this is the last step. A person has finally found a clinical trial. Now we present them with informed consent. Do they understand the language in that information? Are they, really understanding what the trial is about? And so, and then the last part of this is trust. Do you trust your healthcare provider or whoever's presenting this opportunity to you? And so these are some of the barriers that people living with sickle cell disease have in terms of, participating in sickle cell research and in clinical trials.
No, thank you, Cass, for sharing all of those. I think there's a lot of things that Cass has talked about that we've all heard over and over in the sickle cell community. I think it really highlights the fact that there's a lot of work that we all can do from the research community by engaging the patient community, right? So thinking about the steps that a patient or a family member has to go through before making an informed decision about a clinical trial. How do they find it? Is that information something they understand? All the way to once they actually, have all the information that they need to make that decision. How can they even trust what they've been provided? How can they feel like they're going to be very confident and they're going to have that support as they go through a clinical trial or even a survey? I think there's a lot of challenges that this presents. You talk about clinical trials with GOV. It's a great platform for us researchers, right? It's truly, when you think about patients, and not every patient, but the patients that maybe might not be from a scientific background or might just want something simple and quick to really understand, that is something that I think can be very challenging. And then the additional challenge is, how do healthcare providers even present this information to patients? So from our end, one of the things that I want to highlight here is what are some of the things we can do in terms of improving trust and that engagement that Cass shared about. I think one of the first and most important things is how we educate the community, right? There's a lot of myths and misconceptions about clinical trials. There's a lot of concerns, which are valid concerns, that I think we all need to take a step back and find ways to educate the patient community in a very patient-friendly way, so they can truly understand the ins and outs about clinical trials and address all those myths. The second thing that I think we can do truly to help improve trust and engagement is thinking about how do we incentivize and address survey fatigue. Incentivizing can be a touchy topic because sometimes you want to run a study or a clinical trial and make sure you're avoiding all biases. But I think what is fair is, incentivize can be a simple compensation as making sure people have the travel means to get there. People maybe have an additional support. Maybe they might have a kid that maybe they might need support with daycare. All of these things are part of that incentivization. And even think about surveys too. Our community gets a lot of surveys. How do we build that engagement and also be, fair balance to ensure there's no bias? I think that incentivization is key. And I always say, to a lot of community members that reach out to me and ask me why I'm big in terms of talking about incentivization. To me, incentivizing a study or survey research is you saying that you truly respect these individuals for their time, for enrolling in this study. It's not paying people to enroll. It's just respecting people's time and addressing potential challenges that they might present. So I think that's important. The third thing here is advocating for more funding and research. I think that's pretty clear. Cass pointed out earlier on about the 4 current approved therapies. That is U.S. alone. Dr. Jain talked about hydroxyurea being available in India. But if you think about a lot of other countries, those 4 therapies that we have here in the U.S., it's not available. And for some, they don't even have anything at all. So I think it's fair to say we need to continue to advocate for more funding and research, and also enforce the fact that the myth and assumption that a lot of countries are not ready or might not have the resource, that is no longer true. A lot of these countries are ready. A lot of the patient community are ready. As long as things are presented appropriately and correctly, I think that is the key takeaway here. And the last point I want to talk about in terms of building that trust and engagement is building trust with evidence-based advocacy. What do I mean by that? That is truly ensuring that, those of us in the advocacy world, in the sickle cell space, and we're working collaboratively to pull information, to pull data, to pull concerns and maybe, worries that a community have around research, and sharing that back with the research community. I think that is very important. And that can be something that we can always share, whether it's through a patient-reported outcome survey, to really ensure that researchers truly understand, what the community needs, right? Because most of the time, what we typically see is a research gets conducted, and midway or almost getting done, now the patient community gets pulled through. I think it's important that we involve the patient community, the community leaders, the advocacy groups from preclinical phase through phase 1, all the way to phase 4 and post-marketing surveillance. So the community can really feel like you're part of the whole process. And I think that's going to be a good step in the right direction as we keep trying to navigate this challenging space around addressing research improvement for our sickle cell community. So one of the things I want to touch on is, I talk a lot about kind of the key things that we all can do, in our own way to improve research, but we also want to highlight what from our end at Sickle Cell 101, what we are doing and what we truly believe that we can truly join forces, right, to improve this conversation. So what I mean by that is talking about our platform called Sickle Cell Studies. So I gave a preview about this during the webinar 1, but I want to spend some time to touch on this and talk about why this is so important and why we took the time and the resources and the energy to put this together. So what Sickle Cell Studies is, it's a patient-centric platform that has been put together with the primary goal of making sure that the patient community gets put at the forefront of research. Let me expand on that. What that truly means is that ensuring that the patient community have all the tools and resources that they need to make that informed decision that Cass talked about earlier, whether it's helping them understand basic terminology around research, whether it's helping them really understand what are the type of questions they should be asking before enrolling a study, or what are the type of resources they can use to maybe ask further questions with their doctors. We pretty much build this platform to provide all those resources and even addressing all those myths and common concerns that typically come around research. The other thing too is this platform is truly built to really meet the community where they are. I think we all can agree. Look, for me personally, I'm not that tech savvy. I'm not that social media savvy, but that's the world right now. We are in a digital world, a digital global world. And so truly ensuring that we can present research to where the community is being found. We currently have the largest global online platform solely dedicated to research, education, and awareness for sickle cell. So truly, we're utilizing our platform to ensure that we can provide all the research information to the community in a very, very patient-friendly way. And the last part about this platform, and which I think is important, is making available and accessible all recruiting studies and surveys. I always like to point out and emphasize to all our partners that the goal of this platform is not to recruit for clinical trials or surveys. But the goal of this platform is to start that conversation, right? Provide those resources, help the patient community understand the questions to ask, provide content in patient-friendly way. And if by so doing, a person gets well informed and now feel confident to enroll in a study or participate in a survey, now those resources are available to them. So I think for us, that is truly why we've built this platform to really ensure that the patient community, our sickle cell patient community, gets put at the forefront of research, because I truly believe that is where we all have to go if we want to see more improvement in research for the sickle cell community. So let me tell a little bit more about sickle cell studies. So if you go on the platform, just briefly, there's a portion called priority. Dr. Jain talked about how there's no national registry in India. I think that has always been a concern. So we've built priority, and priority stands for patient-reported input and outcomes through research by the sickle cell community. So this is where the patient community can actually come on there and tell us more about what they need. I'm going to give an example in a few minutes, but people can participate in surveys. People can talk about their concerns, or other community members can come there and see results from, let's say, previously completed surveys, so they can actually learn from other people's experiences. We pretty much build this to really ensure there's a central location the community can learn from past experiences, but also participate in surveys if they're interested in. The second part of this platform is that Learn resource that I talked about earlier. So this is where all the resources that we truly believe the community needs to make that informed decision is available. Basic definitions of key terms around clinical trials. What is an informed consent? What is a protocol? What is a phase 1 study? And even looking at the common concerns that come up and how we've addressed those in a patient-friendly way. And even taking it a step further. We have frequently asked questions, right? What are the typical questions that we believe that people should be asking before they decide to enroll a clinical trial? We've pretty much simplified all of this content on that platform to help the community. I talk about the global clinical trial locator we have that is easily accessible, but I always emphasize the optionality in research, right? So it's something that if someone was ever curious to find out what current studies are recruiting around the world, it is available for them to take a look at it and they can make an informed decision. One thing that we do that is very unique is we have partnerships with different universities, different pharmaceutical partners to ensure that we can even take that step further and ensure that one, that content is even further simplified. And also there's always a point of contact. So the community, if someone is looking at a clinical trial, they have questions, they have a dedicated person that they can reach out to, a trusted person, that they don't lose people through follow-up because maybe the content might be text heavy. And the last part is always providing updates, right? So what's going on in the sickle cell world in terms of research? What are some of the results that we're hearing from studies? And we really ensure that we can provide all those resources to the community to ensure that if they come to this platform, every resource they need around research is available, but most importantly, in a patient-friendly way. And we continually try to improve upon that and build different partnerships, right? From both our global partners, pharmaceutical partners, and universities to ensure we provide, just do right by the community. So that is truly like a simplified version of sickle cell studies. I highly encourage you all, please take a look at it if you haven't, www.scdstudies.com. You can always learn about, like I said, we're always here to partner. So please feel free to take a look at it and we can always find ways to work together. So for the last part of our conversation today, we're going to share some examples, right, of some of the ways that we're building this platform and focusing on a patient-centric approach to research. So let's take a look at our first example. This is our most recent survey that we put out. You know, I think this has been one of the big questions in the sickle cell community, right? So we know, of course, research can be improved. So we asked the community to tell us if they had to pick one top choice, right, in terms of what they think should be prioritized for research, what would that be? And I'll tell you, I think what's fascinating here is even though we said top choice, some people chose to give us more than one choice, which is fair. And I think it even tells us that there's truly not just one, there's a lot more that can be done. But I think this is a good learning experience for us in the research community and also for even individual community members to hear from what other people in the community are saying. So this question we give people options, right? Hey, are you thinking the top choice should be drug therapy? Should it be other medical therapies, curative options, alternative treatments, and other? Maybe there's something else that we don't know about. And as you can see here in the middle, this is the results that we've gathered so far from this preliminary survey. There's going to be a lot of follow-ups for this survey. But I think for me, what is very fascinating for me, putting my clinical hat on, is the fact that over 40% of people are leaning more towards curative options being that top priority for research. You know, again, some people might say no or yes, but I think it's important that we take a closer look and understand that this is what community members are saying. Key factor here, people still are interested in alternative treatments, whether it's cannabis, heat therapy, mental health, you name it. There's other things that people are actually interested in and want more information about. As you look at some of the comments that came out from this survey, I think one thing that was fascinating to me is that, you know, you have a lot of people talking about creative options, but people also talk about the other options that we typically don't hear about, which is the other part that I talked about. So let me even expand on that and share a little bit about what people said in terms of other. So for some people, they feel like, you know what, of these 4 options that we provided for them to vote on, that doesn't apply. They believe that there should be something else that should be focused in research, which I think is fair. And I think it's important that we take a closer look at it. So as you can see from these options here, you know, people are interested in getting more research around emergency room appropriate care, physician-patient relationship, genotype awareness, sickle cell trait, mental health. There's a lot of other things that maybe we typically put on the back burner that people are saying, hey, maybe these are some of the things that we should be putting emphasis on around research. And I think for me, when I take a closer look at this study and the results, what this tells me is that, yes, curative options should be very well studied, right, to ensure that they become universal. But truly, there's other key topics that when we keep advocating for more research for sickle cell, we need to take a closer look at from the research community to really, really ensure that we're addressing what the community needs around research.
I just quickly I just wanted to say the community, you know, to Stephen's point, many options were chosen. The task was to choose one, and a lot of people chose multiple, which just I guess shares that we need to look at treatment options, a holistic approach to all of this, right? More than one treatment option. While providing that option, we're providing, you know, assistance in mental health, assistance in, you know, just everything else. And it's not really, I know we tend to laser focus on, you know, just one option and one therapy without, and kind of just blocking out. We have tunnel vision, but we actually really need to expand that and make sure that we are including, you know, all these other factors. I've heard someone say they were cured from sickle cell disease physically, but not mentally. So it's a multi-pronged approach to all of this. And that's what this quick survey study told me.
Thank you. Thank you for sharing that insight. It is very important. Why it cannot be a one size fits all, right? There's a lot of different things that we can look at. The other thing I wanted to share in terms of a patient-centric approach to research is just highlighting very high level, right? So we talk about the importance of sharing back data. So one of the things that we pride ourselves in is making sure whenever we conduct a survey or work with a partner, we share that data back. This is an example of the COVID study that we did to engage the community to learn about their experiences. So you can always take a look at the results here. The key takeaway here is it's always important that we get back to the community. If people participate in surveys in a clinical trial, we have to always share that back with the community. That has always been a concern. And, you know, personally, I think one thing that I saw a few days ago happen was, you know, IMARA conducted a study that unfortunately wasn't successful. But you had the CEO meet community leaders and talk about that. I think those things are important. And so as we all start to think about research, I think it is important that we always come back to the community, share those results, and remind the community that we're truly working together, working through this together. And there's a lot of shared experiences that we can glean in by just sharing that data back. And I think that data share back is very, very important. So the next part, so I talk a lot about, you know, our partnerships, right? And the kind of individual surveys that we run, you know, and also even with different partners. But the one thing that I highlighted with the platform is, you know, Cash talked earlier about so the challenges that maybe from looking at the study on clinical trials of Gov might look like. It is an amazing resource, like I keep emphasizing, but it might not be for everybody. So what we're doing is working with so many different partners to ensure that we can take that content, simplify it in patient-friendly language, utilize videos, utilize simple images to really ensure that people can truly understand it. So if you take a quick look at this example we have here with one of our partners at Ruvent, what we've done is pretty much recreate that study profile in a simplified patient-friendly way. Someone just wants to come in here and just know, hey, I have genotype SS. Am I someone that can, you know, qualify for this study? Simply available to them. Someone just wants to know, if I had a question, is there someone I can reach out to? We really enforce that, making sure there's that point of contact. So truly, we're really helping to ensure that we meet the community where they are by building this patient-friendly content, utilizing this resource. And it's important that we share this example as well. The last part, you know, and again, to emphasize what we're doing in terms of a lot of these studies is how we present this information on social media. And I'll let Cass speak a little bit to this.
Yeah, so just to the point that we mentioned earlier, it's really simplifying, taking all this information and simplifying it, putting it in a way that patients really understand or the community really understand. And so this is that same study that you saw on clinicaltrials.gov. But what we've done is we've taken that information, you know, made it succinct enough to capture the attention of people. So if you, and you know, you see the title here, a study to potentially eliminate pain crisis. That is very intriguing. That is something that I deal with as a, you know, someone living with sickle cell disease. And so the point of all of this is to make this as patient-friendly and as engaging as possible. To Stephen's point, we are not trying to enroll anybody. It really is just so that the community is aware, because awareness is one of those barriers that we have. Oftentimes when after a study is passed, we get so many people that say, oh, I didn't know about that. I would have participated, you know? And so we really just want to bring this information to people where they're at. Social media is where they're at, you know, or, you know, whatever digital platform is where they're at. And we're presenting this information in that way. So these are, you know, sample social media graphics that we get, you know, to help raise awareness of the study that we are working with with a partner.
Thank you. Thank you, Cass, for sharing that. All right. So again, that's really all we wanted to cover today. We've kind of talked a lot about what we are doing from our end. And again, a key takeaway here is we want to collaborate, right? I'll keep emphasizing Dr. Jain's point. There is really not a true global partnership. So we really want to encourage that. and support all leaders in the sickle cell community, whether it's researchers, universities, pharmaceutical partners, to ensure that we're meeting the community where they are. So as we end this conversation, I think kind of the big key takeaway from our discussion today, and even from looking at all the different presenters, is that we need to start working collaboratively, right? To start making collective decisions around how we approach research, creating new standards. How do we ensure that we're meeting the community again where they are? And how do we do this? And it's truly making sure we simplify research for the community, make it a way that people can engage, can understand, and they have ability to ask questions if those come up. The other thing that I want to enforce as we end this conversation is we need to keep working and improving on building transparency around research, right? Whether it's sharing back that data, whether it's good or bad, and letting the community really feel like they're part of the journey is important. And also creating that safe space for people to feel like they can always come to and ask questions. They can come to and find those resources to ask questions before they can make those informed decisions. And lastly, I think it's important that we keep emphasizing and reinforcing optionality in research. For some people, they feel like when they're enrolled in a clinical trial, that's it. They can never opt out if something happens. I think we always have to educate the community about, hey, research is here as something I want to make you aware of. If at any point in time you feel like it's appropriate for you, you have the resources to make that informed decision. But keeping in mind, if you enroll in a study or you participate in a survey and you feel like it's no longer applicable to you, you always have that optionality to drop out. And I think it's important that we reinforce our patient rights through surveys and research for them to feel very confident, to trust us enough in the research community to move research forward. So that's all we have for today. Thank you all as we prepare for our follow-up discussion with the panel, which I'm really excited about. So I don't know if you have any questions from the audience.
Yes, I'm about to share those. So one, thank you, Dr. Tshilolo, Dr. Jain, Dr. Boateng, and Cassandra. Really, really appreciate you all sharing with us this morning. I know we're running a little bit behind time, but I will briefly ask just the questions that have come up so far in the comments. And I apologize if this is a physician, but Dr. Ikomo Emmanuel said, compliments of the day. I want to sincerely thank you. My question is, how can I volunteer this platform with my design skills? And he says right here from Nigeria, but I guess I would expand to say where people are located currently. So how do they help? How do they become part of this? And I think piggybacking on that, there was a question about, do you have the ability to help enroll people? I think you said maybe not, but maybe there's an opportunity to leverage this platform. So if you can kind of group those questions together, please.
Yeah, definitely. First off, thank you. Thank you, Dr. Desai, for those kind words. I think the first person that was asking about how they can volunteer, we always will take volunteers, right? We're a small but mighty team. So please, just like I have on the screen here, please reach out to research@sc101.org and we can really find ways to collaborate and work together, not just in the US, but around the world too. The second part of the question in terms of how to help improve enrollment, again, that's why we reinforce the fact that for us, the goal of the platform is not to enroll, but I think the awareness part is what's key. So we can definitely work together, ensure that we can put studies together in a patient-friendly way, make those accessible to the community. And then by so doing, people are now feel confident that they want to enroll in such a study, that option is available to them. So we highly encourage people enrolling if something is appropriate to them. We're very big advocates in that optionality part of it. So we can definitely work together. And please, anyone, please reach out on this email. You can always follow us on social media as well. That's truly at the heart of what we do. But thank you for those two questions.
Yes, there's two more comments. One is Dr. Makani says, this is great work by Sickle Cell 101. Sickle cell studies look great. Networks to explore partnership with sickle cell studies include Sickle in Africa, CONSA, ARISE, GGTI, and Sickle Cell Charta. And I apologize if I mispronounced any of those, but again, just some opportunities to collaborate. And thank you, Dr. Makani, for sharing that. And then Dr. Cotto actually said there are laws and regulations that limit how much drug companies can directly reach out to patients. Any suggestions on how companies can collaborate with patients on making information available within the existing regulations?
Yes, that's a great question. So that's a question that comes up a lot from our end too. So one of the things that we always recommend, and we work a lot of partners around this, right? So from that early phase, right, when you start to think about building that informed consent, building those protocols. So we highly encourage and work with partners to kind of start that process early by including the patient community. They can give feedback. They can really ensure that whatever they're about to present to the FDA on all of these governing bodies is something that the patient community already has input. I think that is one of the first steps, because to your point, there's a lot of regulating agencies that can, maybe might put barriers around how we present research. So bringing the patient community in early is important. The second part I want to enforce is that, when we work with partners to develop their customized study profiles, like we like to call it, we always ensure we work with those partners to ensure that, whether it's making sure they take a look at it again, making sure it's IRB approved, making sure it's appropriate and legally from both ends, we ensure those things too. But I think key takeaway here is when we involve the patient community in those early stages, before we start to present stuff to these governing bodies, I think that's where the true difference comes in. And we really try to enforce that.
Wonderful and great other conversation happening in the chat. I will continue those conversations, and I will hand this over now to the patient panel. I know we are all anticipating this, and again, I got so much from all of you. And to summarize, there's so much basic work that needs to be done in conjunction with how we do clinical trials and include patients in participation. So thank you for emphasizing that need, and that goes right into our patient panel. Thank you.
Thank you.
Thank you, everyone. And we're now starting the second part of today's session, where we'll be talking to people living with sickle cell around the world to just hear from them what their experience has been generally, and how they've been able to navigate the clinical trial process and how it kind of happens within their country. So my name is Bukola Bolarinwa. I'm one of the co-chairs of the Global Issues Working Group, and I'm also a sickle cell advocate. And so I'm going to start with Osayi really quickly. If you can just tell us your name and your short experience of sickle cell disease.
Hi, everyone. Can you hear me?
Yes.
Yes.
Can you see me?
Yes.
Yes.
Yes. Okay. Hi, everyone. My name is Osayi Olatu. I'm a farmer / agriculturist out here in Ghana. I'm from Nigeria. I'm Nigerian, I would say, and currently live here in Ghana. I had my stem cell transplant about 5 years ago. I was lucky enough to have a younger brother who was a full match. I had it done at the National Institutes of Health in Bethesda in Maryland. My experience with the transplants.
Before we get into that, sorry, really quickly. I just wanted
please guide me along.
Yeah, I will. I just wanted us to just go around and take introductions first, and then we'll go around on experiences. So can I just come to you, Kshitij, as well? If you just introduce yourself and what your experience has been with sickle cell.
Hi. Good evening, everyone. Good morning, wherever you are. And thanks. My name is Kshitij, Kshitij Suryawanshi from India. I am sickle cell homozygous patient living in India. I am graduate in traditional medicine. Here it says BAMS. I'm currently pursuing post-graduation in that, forensic medicines. I worked as a medical officer for 2 years. I am living with sickle cell disease all over my life. I think I will shortly share my experiences with sickle cell disease. Firstly, I was first diagnosed at the age of first got admitted at 9 months. After that, in 1996, I got diagnosed with sickle cell anemia. At that time, there were no compulsory prenatal diagnostic or sickling test advisable any. Nowadays, there are prenatal tests advisable. I could get frequent transfusions and other hospitalizations in the period of 2003 to 2008. Most of my admissions are because of mostly of joint pain, unbearable chest pain. My each time, each in each crisis, I think my WBC counts were always raised. Though I was administered all the vaccination according to Indian vaccination schedule, including pneumococcal, I got admitted for frequent lung infection, pneumonia, severe pneumonia. In 2004, there was severe abdomen pain, and I was diagnosed with cholelithiasis, gallstones. And at that sonography, I also discovered, my doctor also discovered I had autosplenectomy. There was no presence of spleen. For that, for gallstones, I got operated in recently, 2019. Cholecystectomy was done. Up to 2009, I was only on medication of Folvit and zinc supplement. Until up to very late, I got started on hydroxyurea in 2017. I got operated for THR. One of my leg got avian in 2013. After that, I got operated in 2016. At that time, at the period of hospitalization, my left leg also started paining. Later, that also got avian diagnosed. There were many close encounters like severe anemia and other lung infections. One time my HB was 2.45 grams. There were many, one time thromboembolic episode was seen in me, that was saturation was very dropped. As Dr. Jain said, there are many patients in India who live in tribal and distant areas. That is a very main concern. I live in town called Pauni, about 100 kilometers from Nagpur. So at the time of transport, I think my time is very short. So I will end my medical history here.
Thank you. Thank you, Kshitij. Yeah. And thank you so much for sharing your experience. I'm going to go to Alicia. Just like 2 minutes. Tell us a little bit about yourself and your experience living with sickle cell and where you're from, where you live, and so on.
Sure. Hi, good day, everyone. Good day, good morning, good evening, wherever you are. My name is Alicia Turner. I'm from Jamaica, and I am an adult living with sickle cell disease. My genotype is SC. I am also one of the vice presidents of the Sickle Cell Support Foundation of Jamaica. So once again, I want to thank you all for inviting us to partake in this very informative platform. My experience with sickle cell, I was diagnosed at approximately 12 months old. That diagnosis came from pretty much me just living at the pediatrician, always getting ill, the swelling of the hands and the feet and so on. So over time, that is when they made a decision to test me for sickle cell, and the result came back with SC. So it's just things like that highlight the need for screening, for newborn screening, because we all know that at the very tender age from newborn is when it's most critical. So in terms of my experience living with sickle cell, overall, I can say I would believe that I have been one of the blessed ones. I'm gonna say that so far in terms of not having major complications, but I have experienced splenic sequestration, where my spleen was removed at the age of 5, I believe. I had to have my spleen removed, and ongoing bouts of, acute chest syndrome, just very intimate with pneumonia for some reason. So I've had several instances of that. My last hospitalization was in 2019. I had another episode of acute chest syndrome. And since that, I've just been trying to manage my illness in terms of medication. I generally just try to stay on top of my vitamin C and zinc. I also had tried, we haven't really mentioned much in terms of alternate medication. even Flow, which is by Dr. Shirley, where that's an alternative medication that kind of helps minimize the pain and so on. That has helped me somewhat. I don't have immense painful crisis, but I do experience joint pain from time to time. So I do also take medication for my pain, such as meloxicam, Panadine, etc. So for example, like this past week, you may hear me sounding a bit hoarse right now. I'm actually recovering from a cold right now. I had fever and so on. So just in terms of being able to access the healthcare that we have here, which is very good healthcare, if I may say so, and keeping on top of that and ensuring that in terms of my chest issues and so on don't recur. So that is pretty much a synopsis of my experience with sickle cell.
Thank you so much, Alicia. That was really interesting. And I think lastly, we have Shirley.
Hi, my name is Shirley Miller. I live in Charlotte, North Carolina in the U.S. I have sickle cell, my genotype is SS. I am 66 years old, and I've had a lot of experience with research in that I've joined a lot of research studies. And I've also been an advocate for sickle cell for very, very long, having worked in 2 comprehensive sickle cell centers and just done a lot of advocacy work on the Hill and everywhere.
It's lovely to have you, and thank you all so much.
Have a round of applause, please.
It's lovely to have you all. Thank you so much for obviously taking the time to share your personal experience and really help us understand what it is like from the patient's perspective. Because I think that sometimes, like Stefan has like so rightly put out, that is often missing when we are talking about clinical trials as a whole. And so I'll pass on to Stefan to just ask some questions generally on what your experience with clinical trials has been like, and obviously speak generally about it as well in the various countries that you live in.
Yeah, thank you. Thank you. So again, thank you all panelists for being here today. You know, I think hearing from you all's journey truly inspires all of us. Of course, today is Clinical Trials Day, right? So we have to kind of dive into that tough, touchy conversation. So I'd love to, you know, take a few minutes from each individual and learn about your experiences in terms of clinical trials in general, whether you've participated or not. So we really like to kind of hear those perspectives. And I would like to start with Alicia, if you don't mind.
Sure, no problem. Thank you for having me again, Stephen. So in terms of my personal experience with clinical trials, I don't have any experience at all with that. In terms of research, clinical trials, not much on my end. I do know that we have participated here in the island of Jamaica through the Sickle Cell Clinic, which you probably have heard about it. We've participated in a lot of trials and so on. In terms of access to the trials, I believe that's mostly funneled through the clinic for many reasons, such as, you know, they would have the information in terms of access to the patients and so on. I had invited my colleague Annabelle to join us today because she has actually participated in the stem cell gene therapy. However, unfortunately, she was actually hospitalized last night, so she wasn't able to make it here today. But she would have had lots of information in terms of her going to traveling overseas, doing the gene therapy. I can't remember exactly what year she did it. I believe it could have been 2017. Don't quote me on that. So she participated in that, and it had pretty much worked. She felt amazing for the first year, let's put it that way. But in terms of after that, she has unfortunately, you know, developed a lot of complications after that. But one thing she did want to take away from that is that she would, in her opinion, she believes that it would be better if some of the trials are probably offered at an earlier age, where some of the complications haven't already started. So for example, she may have had complications such as AV and avascular necrosis, which she is currently suffering from. And she believed that probably started before she did the clinical trial. So she wants, so to speak, say, you know, that was not, it didn't work for her specifically because she probably thinks it had started before. But as I said, for me personally, I haven't been part of any. I do know that the sickle cell clinic, through the wonderful leadership of all the directors we've had, dating back to, Professor Graham Sargent. We've had, Professor Jennifer Knight Madden, she's currently on this call, as well as the current director, Professor Asnani, Monica Asnani. They're wonderful in leading this research that we've had and participated in the global initiative to try and do research and trials for sickle cell disease. I recently heard that we were participating in the newer drugs. I'm not going to attempt to pronounce the names, but I recently heard that we participated in those. So I'm very happy for that. And I do know that we have ongoing participation with the use of hydroxyurea, and also in terms of the treatment in preventing strokes. And we know that that's a major complications for the young children. A high enough percentage of young children suffer from strokes locally here. So that is something that we are currently researching on. But yeah, in terms of the access to it, I would like to see greater access to clinical trials. The information, it is a touch and go situation because it's about the access. As Stephen had mentioned earlier, most of it would probably be presented on social media, which not everybody has access to, unfortunately, even though we might think it's so easy to access. A lot of our members, especially being a member of the Sickle Cell Support Foundation, a lot of members are unfortunately what we call impoverished based on having sickle cell and not having able to finish school, not be able to have a job because of not having to finish school, and that ripple effect that it has caused. So they're not even able to afford a smartphone. So you might find the minority are actually able to be active in our foundation and actually able to be active members even of the sickle cell clinic, because as simple things such as transportation, there are persons who can't even afford transportation to get to the clinic as well. So you have persons who might be missing out of that loop in terms of getting access to the information on what is available. So in terms of how to fill that gap, I'm not sure. In terms of it might be best to funnel it through maybe the local hospitals, really present it to the doctors there. And then because it's an island-wide situation that we have, the sickle cell clinic is located in Kingston, which is the capital of the island, and not everybody can travel to Kingston to get healthcare. So they have to rely on the different public hospitals in what we call the parishes here. So if we can probably get information to the hospitals, and if possible to the private hospitals and clinics as well, then they could probably have it on a bill on the notice board, let the doctors be aware of it, and let's say, hey, if you are interested, if you can, here is where to get more information.
Yeah.
In terms of the willingness to participate, I do believe that there are many persons who will be willing to participate in research and clinical trials, especially persons, we have a saying that we're just sick and tired of being sick and tired. There are many persons who are like that. They're desperate and just over it. They're tired of suffering. They're tired of the pain. They're tired of the stigma. They want to get on to have a normal life. They like to go back to school. They like to get a job, be independent. And they'll be much willing to try anything if it might possibly even work. Yeah. So you do have persons like that who are willing. The unwillingness may come from where, they might not sure exactly what the outcome might be like in terms of, is it going to work? Is it going to make me worse? There are some stigmas attached to participating in research. Yeah. However, I do believe that most persons, if they are educated enough and if they have that support, they would be willing to participate. And I speak of support as well in terms of, it's going to come back again to financial support, as I mentioned before. For the medication, for the drug trials, those are a little bit simpler because the drugs can always be shipped here and can be monitored through the local clinic or the hospitals. If it's a case where the person would have to travel overseas, other than getting that hurdle of possibly needing a donor to do a stem cell transplant or whatever, if that's not the case, then we'd actually need to say, okay, are we going to get funding in terms of assistance for transportation, accommodation, et cetera, because as you can imagine, that would be a major blow financially for someone to be able to access to travel overseas.
Yeah,
so
and
that,
so one thing that you shared that was very insightful for me, right? It sounds to me that, you know, even on that island, access is so very different based on where someone is located, and even talking about providing more resources to the private hospitals as well. I want you to hold that thought because I want to actually expand more on the access. I want to go to Osayi because, you know, Alicia just shared her unique perspective from where she's at. Osayi, you have a very different perspective too. So if you don't mind, share with us, you know, your experiences so far around clinical trials.
Hi, everyone. Yeah, it's interesting. Nice hearing everyone's perspectives and opinions. I hope you can hear me clearly. Is that okay?
Yes, it is.
Okay, cool. So I like I was saying earlier on, I did my transplant about 5 years ago. For me, initially, yes, it was, you know, a little bit of it took me about, I would say 2 years to say yes to it. But the moment I said yes, I never looked, you know, I never looked back. I think for me, the reasons why I didn't was, like I said to earlier, if I said to the doctors, I was like, what's the worst thing that could happen? And they said the worst thing that could happen is you would revert back to having sickle cell. So for me, that was a chance I was willing to take. I was fortunate enough to have a family that were able to provide the support, like the lady said, you need that support, that financial and emotional support, right? That those two things are very, very important. In my, I guess also, I would say thanks to God. When I got to the hospital, they actually did a total body checkup. They literally checked everything from my eyes to my ears to my teeth to my lungs, to make sure there was no, pre-existing conditions. Obviously, while I had sickle cell, my spleen had ruptured over the years, so they knew about that. I also had my gallbladder taken out while I was in university, so they obviously knew about that. But they still went ahead and did a total check, a thorough check of my body to make sure there weren't any issues. We did find out that I had malaria when I came in. It took us a couple of months to get rid of that, but we did. And then after that, we went ahead and did the transplant. My younger brother was my donor. He was a full match. And I think for him, he said it was a pretty painless, operation. They had him on a bed maybe for about 2 days. They took the blood out from this end, put it into the centrifuge machine, which then took out the platelets and the red and the stem cells, and then the rest of it went back into his body through his hands. He experienced a lot of fatigue and tiredness, but they gave him drinks and a couple of things to help with that.
Yeah. I want to chime in here quick, Osayi. So, and again, for all the audience, please put all your questions in the chat. There's a question that has come in, I think, for your perspective. I'd love for you to comment on that. So, you talked earlier during your introduction that you traveled out of, what has gone on Nigeria to have this process, right? It took about 2 years for you to say yes. Can you speak a little bit more to, the fact that you had to travel from one country to a different country to go through, such a process and how that was like? If you don't mind speaking a little bit to that, that would be great.
So, I mean, it was a bit difficult, right? But I also think that the frame of mind of where you are at a certain time in your life could help push and motivate you to go ahead and be bullish about certain decisions. Prior to that, what actually made me pick up the phone and call them, I had a really, really bad crisis while I was in Lagos in Nigeria. and the treatment at the hospital, which was supposed to be one of the best, was absolutely, rubbish. So getting out of the hospital, I said to myself, I'm gonna go in Nigeria. So prior to me living in Nigeria, I actually lived in England for 11 years, where I could pick up my phone and call the ambulance. I could run into the A&E, whatever it is. I had a good healthcare system on my back.
Yeah.
So moving to Nigeria as an adult, I didn't have that anymore. And I think that was what kind of prompted me, because I kind of realized what I was missing and how not having that means I might not be able to do the 11 years I just did in England, So that was what really prompted me. I picked up the phone and I remember saying to the lady, I have a 6-month calendar where I can wipe everything out and dedicate this to you. Would you have me? But that has to happen in, we need to go in less than a month. And yeah, so she called them, squeezed me in, and that was how I was able to jump on the plane and get on it.
Thank you.
Going to a new country, for me, it wasn't really a big deal. I'm fortunate enough, again, I would say, to travel to the States very often. So I'm quite familiar with the States and whatnot. So that wasn't really much of a I would say, culture shock or anything.
Yeah.
Yeah.
No, thank you. Thank you for sharing that. I think, one of the things, and I see some comments coming in saying amazing experience, Osayi, from Africa, Europe, and America, right? I think what's being stated that's very clear is the experiences vary by country, right? And then again, I think these things are important for our community to factor in. I saw one comment coming in talking about infrastructure and how that is so different from country to country. And I think hopefully this really will reinforce the fact that there's a lot more work that we need to do, not just improving research in specific countries, but all around the world too. So thank you for sharing that. Kshitij, I want to come to you. If you don't mind, I'd love to also learn about, your experiences in clinical trials in general, whether you participated or not, or anything else you can share.
You asked me, I think I, on personal level, never participated in clinical trial, and I think none of my friends participated in the clinical trial. We work in a advocacy group, I think, in Central India. Dr. Jain and I have contact with that group. So I think no one is participated in clinical trial, but I had known about some studies that Dr. Jain was taking on low dose of hydroxyurea earlier. I have known about that, but not particularly on clinical trials. Advanced treatments and clinical trials are good and must. It is a need of time, but for me, the priority is for early medical care is provided to all sickle cell patients. India is a huge country, I think, and we are a lot of patients. And as Dr. Jain said, Dr. Jain was working in Nagpur. It is tertiary medical center, about 500 kilometers, say to 500 kilometers. If patient gets serious, it is get referred to Nagpur ultimately, where Dr. Jain is working. There is a lot of persons in that 300 areas, 300 kilometer radius that are, I think we need here at least many, I can say, basic medical structure, basic medical treatment, all distance area and tribal area is necessary. I think public health system is also needs to be get upgraded, because not all patient can rely on private hospitals. There are a lot of people. I don't think it's only matter of India. As earlier said, the sir from Africa, there is also lack of funds, and sickle patients are suffering. For me, I think priority of primary medical care, basic medical medication like hydroxyurea, folate, and zincovit is important. Clinical trial is necessary. In this well-connected world, I think everyone of sickle cell disease needs equal and proper medical care all around the globe. I think scans and other diagnostic procedures needs to be improved so early interventions can be done. So no patient can go to a very invasive procedure like THR. I have gone. When I got THR, it was I don't just nowadays I don't really suggest someone for go to THR because I get a very bad experience about it. And so scans are very necessary, and medical society needs to get produce Dr. Jain and Dr. who are working in sickle cell, because they are working deeply in sickle cell. Sickle cell doctor and other clinician and pharma companies see in other way. But in our, I think, patient's mind, it's all us, not just a number or a study subject, I think. Research should be done. Research is necessary. Without research, we are going nowhere. Research must be done, and it should integratively, so all can take something from it. There is only we say about hope. We can hope something about it, but for my priority, there is a lot of things other than clinical trials. I think BMT is clinically tried and approved above 90% success rate in BMT in children are happened very at early years, I think. Now it is successful procedure. I think Osayi is very lucky to get BMT in at clinical process. But I don't think in India that no one in my circle is opted for BMT. Maybe there are lack of community engagement. We need to communicate with advocacy groups, sickle cell group, so they can enroll in clinical trials, and that's, I think, how I view about it, clinical trials. No one, I think, in India is. I think Dr. Jain will share about clinical trials and other things, but for me, basic medical treatment and primary medical care and other things are necessary.
Thank you. Thank you for sharing that, Kshitij. I see Dr. Jain's hand is up, and we're going to be cautious of the time, so I'll be turning over to Bukola very shortly. But before I pull in Osayi and Dipty, I would want to pull in Shirley in here. So Shirley, you talked earlier about your experiences in different research, right? So you guys, I work with Shirley in so many different capacities, and I know the amazing work she does. So Shirley, speak to us, right? You live in the U.S. and share more with us in terms of your experience in general around research so far.
Okay. I grew up in Florida, and I didn't know anything about sickle cell or research, and it was a very difficult time. And I had most of my hospitalizations in my younger years. But I moved when I turned about 30, and it was because, the thing about you're going to die by 30 or whatever. So I waited and waited. And when that didn't happen, I decided to take control of my own life, and I moved across the country so that I could get better care and also be exposed to things. So I was pretty much more knowledgeable because I started going to the sickle cell conferences and learning what was out there and what clinical trials you could be involved. So I had all of my clinical trials at the NIH, starting with pulmonary hypertension, leg ulcer, 6-minute walk, and then long-term follow-up. So all of them were done at the NIH, and I would do another trial if I were eligible. I feel like I get screened out because of my age. Most of the things go to 40, and I'm 66 now, but I'm doing very well. So if I didn't have to do one, it's okay. But I would go to another country also if it was advantageous for me. So that's what I have to say.
That is very interesting. And thanks for sharing that perspective. I think one thing we can glean from this conversation, and this is why this global conversation is important, the experiences are so different per country. And, Kshitij, you talked about, when we think about research, we're usually talking about clinical trials, but it's a lot of ancillary factors that need to be put in place. You cannot talk to people about enrolling a study when basic healthcare is not even available, basic resource. So thank you, Shirley, and thank you, and panelists. I want to pull in Dr. Jain. I see your hands up. So Dr. Jain, any comments you had to add to that? And Bukola, you can take it from there.
Just a minute. probably missed that slide during my talk. There are around 400 bone marrow transplant done for sickle cell patients in India. It's like medical tourism, but most of the patients are from Kuwait and Africa. Only 20 patients of these are from India.
Okay, thank you. Thank you for sharing that. I see we have 6 minutes, so Bukola is going to moderate the last part, but hopefully we can get some key takeaways from the audience. So over to you.
Thank you so much, Stephen. And I knew that this was going to be a tough one to keep into time because there's so much to discuss. I was actually going to tell Dr. Jain as well that, and this is something that we had discussed in the preparation call for this with Kshitij. So I've worked in Nigeria for at least 6 different patients who have gone to India and carried out successful bone marrow transplants, but they have paid usually between $10,000 to $15,000. And so it was really interesting to speak to Kshitij and hear him say that he didn't know any Indians with sickle cell who had taken part in bone marrow transplants, given that I know a lot of Nigerians and people from other West African countries who have actually traveled to India to take part in bone marrow transplants. And I think it brings us back to this issue of access and what are all these different factors that are limiting people from being able to access clinical trials and sometimes basic, medical care. So I'm going to quickly come to Osayi as well, given as someone that's had that experience. I know you had your hands raised. Did you want to quickly share some of that for us?
Yes, sorry, I had my hands up because I actually have to run for a meeting. So I just wanted to see if you guys needed me for anything else. Sorry, Buki, what was your question?
No, so it was around like being able to actually find the trial from somewhere, from you, how you were able to find the trial from Nigeria to take part at the NIH.
Okay, so for me, I found out through a friend who knew someone, right? And that was how I was able to contact them and whatnot. But I think to face the real issue, which is access, I think the main problem is, like he explained, like Kshitij explained on our prep call, right? He lives in, maybe some city or town that's outside of Mumbai or outside of, one of the main cities. Chances are, if there's investment being done in that type of healthcare, it's going to be put in an area where the people who can afford it will be, and it would obviously be marketed, and this is how things work in the third world countries. It would obviously be marketed around or to the people that they know can afford it. And that brings us back to, my last thing, because I have to go, technology transfer, right? We need to look at, okay, how do we get these guys who have the money, who have built their technology in India, in America, like the NIH, and in Europe or whatever, how do we get them to then come into other parts of the world, like Africa, the Caribbean, and other parts of other parts of India? I know a doctor in Edo State in Nigeria who has successfully done, I think, maybe about 8 so far of these, and it's the same thing that nobody knows about him. And the reason why he doesn't have that many clients is because I think his cost about 10 or 11 million naira to do it, which in the grand scheme of things, to a certain extent, isn't outrageous if India is doing it for $10,000 to $15,000. So we just need to find a way, okay, if we can transfer this technology to our doctors over here, are they able to do it in a more affordable way? Which then, I think there has to be a collaboration where the larger people like the NIH and all those guys partner with the Nigerian doctors or African doctors and all these doctors who are already doing this in different regions, and find a way to, I'm not saying subsidize, but just find a way to work together in a bid to make it more affordable, for anyone else, not everyone, because that's healthcare. Healthcare has never been affordable for every single person in the world. But if we can find a way to make this more affordable for, you know, the average man in these countries, then and I think the only way we can do that is, you know, technology, some sort of partnership that includes technology transfer, but also some sort of financial incentives or you know, something. I don't know. I don't have the answers.
I know. I don't think any
I
one
have to
person.
run because
Thank
I
you
have
so
a
much,
meeting
Osayi.
at 2:30 and it's 2:39 now. But
Thank you so
you
much.
guys have fun and enjoy.
Yeah.
Thank you. And I see that in the chat as well, Dr. Ife and Dr. Makani and Jennifer Knight have all been discussing some of these issues around access. And it's a really nice way to kind of bring the webinar to an end. And obviously the key messaging from a lot of people is that there is a willingness within the community, within the sickle cell community, to take part in clinical trials. It's just that, you know, the access has to be there, and patient-centered trials have to be the way forward, kind of as Dr. Stephen has said, so that people feel part of the entire process. And while we're doing that, while we're thinking about clinical trials, I think Kshitij raised, for me, the most pertinent point in this webinar is that we can't have clinical trials if basic hydroxyurea is not available, if basic healthcare isn't available for a lot of people living with sickle cell around the world. So I just want to thank everyone for giving us their time today, and especially want to thank our panel of sickle cell warriors around the world for really today on Clinical Trials Day, just really sharing their experience with us and giving, I think, the entire medical community and patient community something to think about. I'm going to pass it on to Tessa to wrap it up. And yeah, thank you so much, everyone, and have a good day.
I think you did a great job with us, Pookie. But you know, as I will just say, we are the Sickle Cell Disease Coalition, so we are a international network of various stakeholders working to hopefully unite these various efforts that are happening around the world, so we can collaborate and coordinate, and again, tying these dots more across different efforts. So this has been really wonderful ideas, and obviously we're going to look back and do a lot of brainstorming of how we can kind of further the needle with the coalition and address some of these great points put out today. But any additional thoughts, we welcome to our email at coordinator@scdcoalition.org, and we will keep you posted with the recording of this and any updates about our next relevant activities. But thank you all, and we appreciate your time and hope everyone has a great weekend.
Thank you, everyone.
Thank you. All the best to everyone. Bye-bye.
Thank you very much.